This week on the BackTable podcast.
Let's talk about this guy, 67-year-old male. He also has HCC, but this time he has portal hypertension. As you can see by a big spleen there, 10-centimeter tumor. Sid, at your tumor board, what are you guys looking at?
With portal hypertension, it looks like he's going to need at least a right. I'm assuming not an extended right hepatectomy. And I don't think our surgeons are going to do an operation. Correct me if I'm wrong. Would you do a surgery here?
I would not.
You did not. Don't worry on this one.
And so without macrovascular invasion, this patient's going to get local regional therapy. The question becomes, are they going to be ever considered for a liver transplant, with downstaging? And that's always a huge gray zone as to, what is the official downstaging criteria. I would argue there's nothing official anymore. It's, it's kind of individualized at this point. But we would start with local regional therapy in this case, and given the size of the tumor, it would be a radioembolization.
Welcome to BackTable Tumor Board, your source for the latest on multidisciplinary cancer care.
Awesome. Well, welcome to our little makeshift tumor board. I think we have most specialties represented. And so before we get started with our tumor board, I don't know if you guys want to introduce yourselves.
Sure, I'll start. My name's Adam Burgoyne. I'm a medical oncologist at UC San Diego.
I'm Heather Patton. I am a hepatologist at VA San Diego.
I'm Zach Berman. I'm an interventional radiologist at UC San Diego.
I'm Siddharth Padia. I'm an interventional radiologist, not at San Diego. I'm at UCLA.
And I'm Gabe Schnickel. I'm a transplant and hepatobiliary surgeon at UC San Diego.
Well, awesome. Well, thanks. So we're going to talk about HCC care and kind of how we would discuss a patient at tumor board throughout a whole different variety of scenarios today. So hopefully it's a lively and not too contentious discussion about the different options we have. So in general, I just want you guys to assume that unless otherwise stated, patients have normal liver function and otherwise are completely capable of, let's say, getting a transplant from a psychosocial, financial, etc. So we'll just kind of assume all options are available for all these patients. And so I think a great way to start would be this first case right here. So as we see, we have a 60-year-old male. He does not have a history of cirrhosis. He has a biopsy-proven HCC. It's measuring 28 millimeters right here in the middle of segment 5, 6, somewhere in there. It's an LR5, but as I said, it's a biopsy-proven HCC. So if this was presented at your tumor board, what are you guys thinking?
Well, I guess I'll start off just with a general statement that, our goal is always, when possible, to pursue a curative option. And with a single lesion of this size, no cirrhosis, I would probably first be talking to our surgeons to see if they felt that it was surgically resectable.
Thank you, Heather. I'm flattered. I think that would be also certainly my approach would be surgery for a patient that's without cirrhosis that's got a moderate size HCC. I think the size being under 3 centimeters, one also has to consider the utility of thermal ablation, which is a nice durable option for patients who aren't surgical candidates or who aren't interested in surgery. But I think this particular case, is amenable, at least from the images that I see, it's certainly amenable to a surgical resection.
What sort of surgery would this require? Can you do a wedge for this, or would this require some sort of anatomic resection?
Yeah, I think you can do kind of a larger partial hepatectomy, wedge, or segmentectomy. I would have to see a few more images to really look at the vascular anatomy and see how that plays out. But I think you can do less than a lobectomy on this one.
Dr. Padia, if you were to see this patient, what sort of therapies would you offer?
So, I agree with these guys. They probably get offered some kind of curative intent therapy. And let's say they're not a surgical candidate for whatever reason, or let's say they don't want it. When we're talking about this is easily amenable to a lot of local regional approaches. And so our preference has been to either do a thermal ablation, in our case microwave ablation, or to do a radioembolization. In this case, I'd probably favor a thermal ablation for a couple of reasons. Number one, it's under 3 centimeters. It is well defined, well circumscribed. There doesn't seem to be infiltrative margins. It's also not subcapsular, so from a technical perspective, it's pretty straightforward. In terms of radioembolization, I think that's also a great option. The one downside is that you may have to cover your perfused territory in doing a Y90 in this case may be more than you think it is, because you're going to have to hit all that peripheral liver as well. My preference here would probably be to go with a thermal ablation as my first choice.
And how about systemic therapy? Any role here?
I mean, I think the concept of perioperative systemic therapy is interesting from a research perspective, and there's been some small studies that have suggested that neoadjuvant immunotherapy may be something that's coming in the future, and that's helpful for us to understand the disease biology of these patients, get them sort of a test of time on immunotherapy. We've seen some great responses, including complete responses in some of those folks. But in terms of where we're at in 2024, no real role for immunotherapy. This person has a small unifocal tumor, and the risk of recurrence, unless there were surprise features on the pathology, is probably low.
And small tumor, no cirrhosis, do we offer liver transplantation?
We would not typically pursue transplant for a case like this. Yeah.
Okay, great. So this patient met with both a surgeon and an interventionalist. They ended up choosing to go with thermal ablation, which they ended up having a complete response.
I'm a little bit hurt.
I'm sorry.
That conversation didn't go very well, apparently. Or maybe Sid is just more persuasive.
Yeah.
Exactly.
Well, don't worry. Your time is coming, because now we have a second patient, 68-year-old female, also doesn't have cirrhosis, has this LR5 lesion up here. It's measuring 47 millimeters up here in the segment 7, right along the liver capsule area. Thermal ablation still an option, or
Did they get a biopsy?
This one is also biopsy proven HCC.
Just because no underlying cirrhosis, our practice is to get a biopsy. You can't assume that it's going to be HCC in a non-cirrhotic. So this is well beyond most ablation guidelines, including ours. While a thermal ablation is technically feasible, the recurrence rates are sky high once you start getting above 3 centimeters. In our series that my colleagues published, the recurrence rate after a thermal ablation is about 15 to 20% at 1 year. So to me, that's pretty high when you compare it to, let's say, if you can do a partial right hepatectomy and you get an R0 margin, your recurrence rate is probably in the single digits or even less, right? So my preference would be to see if you can do a partial right hepatectomy.
Oh, thanks, Sid.
See, that would be my conversation with the patient. Say, go see our surgeons first.
Yeah, I agree with that. I think that's at least from what we see, very amenable to surgical resection. I think that's the best option for a tumor that size. And I know that, Adam, you had a study open that looked at adjuvant in this setting, right? That would meet the criteria for size. I can't recall exactly, but
The cutoff for most of the adjuvant studies was 5 centimeters. So, on the resection tissue, it could be a bit bigger, depending on what that would be the size that we would use. Adjuvant data is still coming. That study that we were participating in actually has not read out yet, but others have. The kind of most press has come from the IMbrave 050 study, which on its initial data analysis did look like there was an improvement in recurrence rates for those patients treated with adjuvant atezo-bev for a year versus those who were surveyed. Unfortunately, subsequent data analysis has been less promising, and it looks like those curves are mostly overlapping at this point. So I don't know that adjuvant atezo-bev is going to be the answer for such patients, but as I mentioned, there's other ongoing studies that are large phase 3 studies looking at different combinations of adjuvant immunotherapy that may have some promise.
I mean, if this patient was, let's say they refuse surgery again, right? Like the first one. From a local regional therapy standpoint, while ablation to me is off the table, it's easily amenable to a radioembolization, right? So this would be most likely a straightforward Y90, and in our series of patients with 5 centimeter tumors or less, we're looking at objective response rates in excess of about 96, 97%.
Yeah. So Gabe and your colleagues won this battle, I should say, and she ended up going for a right posterior sectorectomy, and she did quite well for 6 years until she eventually developed a recurrence, and this is what the recurrence looks like. Unfortunately, not a transplant candidate due to concurrent alcohol use, and has expressed a strong interest in not stop drinking. So now we have this 26 millimeter recurrence, knowing that she did have a previous surgery. What's our thought process here? Would you repeat surgery?
If she still, despite her best efforts, has no cirrhosis, I think that's amenable to resection as well. And it's a smaller tumor. a little bit more painful on the surgical end with her previous hepatectomy, but I think it's definitely feasible considering it's on the contralateral side. And yeah, I think you can get away with doing it without taking too much liver. So I think that would be an option still.
And if she wanted to explore alternatives, what about the location for thermal ablation?
So I think that the biggest concern from a location standpoint comes due to its proximity to the stomach. This is a single slice, so it's one of those where you have to really kind of study it both in axial, coronal planes, et cetera. From a thermal ablation standpoint, I still think it's safe. If we were too close, this would probably be a relatively straightforward hydrodissection where we could put a small needle in between that segment 2 and the stomach and instill half a liter of fluid and should be fine. That being said, I think either a thermal ablation or a segmental radioembolization would be potentially, get us a complete response in this case in greater than 90% of the time. So I think it ends up being dealer's choice.
Okay. And how about now with recurrence? Are we starting to talk transplant yet? Or are we still...
Well,
assuming she would ever stop drinking.
Right, exactly. Yeah. We led with that. So again, the fact that she is not cirrhotic and there are other options with potential curative outcomes, we would not pursue transplant for her.
Gabe, question for you. Do you worry about continuing to chip away at someone's liver like this that is still drinking? She's thankfully not cirrhotic now, but obviously at risk.
Yeah, definitely. I think the more liver you take out, the more at risk she becomes. I think that's a bit of a challenge, right? Because if they're not taking care of themselves and doing what they need to do to prevent their, disease progression, it gets very frustrating to be chipping away at a problem that's just going to keep popping up. Because once you have one recurrence, the odds of getting a second recurrence, it goes up substantially. So it's a good point and definitely frustrating and really you got to have real heart to heart, I think, with patients like this.
And probably say to the hepatologist, like, why don't you get this under control?
Right. Darn you, hepatologist. Awesome.
This patient chose to go with radioembolization. We didn't feel that the stomach would be very easy to hydrodissect away. And ended up having a complete response and is doing well to this day. So now let's go a little bit more advanced. This is a 69-year-old male who also doesn't have cirrhosis, but has multifocal HCC. So this is an aggressive BCLC-B, technically. Definitely no macrovascular invasion that we can see. Bilobar, really a dominant 12-centimeter tumor, kind of in segment 5-6, but also has some 3 additional small lesions up in segments 2 and 3. What does the discussion at your tumor board sound like?
Yeah, I'll jump in first by prefacing this by, I think there was actually a recent study that just came out that shows there is still benefit for multifocal HCC and resection, whereas historically we were like, once you have more than one tumor, we'll probably need to move in an alternate direction. That said, I think the disease burden and the locations of the tumors, I think surgical resection is not really on the table.
So I think in a case like this, there's, in my mind, no question that we need systemic therapy. I think the other question is, with the dominant lesion, would there be role for also doing a radioembolization to where you have that cluster of disease?
Yeah, I mean, at our place, this patient's gonna, if they're eligible, gonna get a clinical trial. And, I think most of our clinical trials have largely focused now on these advanced stage, bad terminology, but late BCLC-B patients, right? Which this patient is. So let's say they were not interested in a trial. We would probably, then it becomes kind of this argument between systemic therapy and local regional therapy. My argument for a local regional approach is that, at least for systemic therapy, has really been studied in BCLC-C. And when they looked at the BCLC-B subsets, let's say we look at IMbrave 150, there's not a huge signal actually in the BCLC-B subset. It's really in the BCLC-C or the advanced stage. So my preference is still to at least lead off with a local regional approach. They're Child-Pugh A, if they're functional. It depends really on how many of these small tumors you see. Zach has highlighted 3 of them. There may be more. We don't really know. It's hard to tell until you do an angiogram, and you may find 10 more. And so that's been our approach. And then the question becomes, do we tag it with a systemic therapy right afterwards? Do we restage and then consider systemic therapy? And those are kind of open-ended questions. This is where kind of the art of medicine comes into play.
I agree with you on point one. Point two, we may disagree on. All patients, I should have led with this like Heather did, should be offered clinical trials when available, particularly these patients that are, non-cirrhotic, well compensated. So whenever we have a clinical study, we know that patients with any types of cancer, including HCC, benefit from being offered clinical trial enrollment. So that would be my preference as well. I do think with this amount of disease by lobar, starting with systemic therapy is what I would offer the patient. I think that you lose little from that approach. And if you have someone that falls into that category of being a partial responder or even a complete responder, which we do see sometimes, we save that person the additional toxicity of a local treatment that they may or may not need. And at this point, we don't really have data would save or prolong their life in the way that we do the systemic therapy would hopefully improve overall survival in this standpoint. But I do think that, again, in the clinical trial space, the idea of combining local regional therapy and systemic therapy is very interesting, particularly for patients like this that have like a large dominant lesion, because we may find if we collect the data that it does help.
My issue with the clinical trial or the data published for systemic therapy up till to date, there's no description on tumor size, tumor number, tumor burden. I mean, it's not there. IMbrave 150, what's the average tumor size? I don't know. Is it 5 millimeters? Is it 5 centimeters? Is it 50 centimeters? And so I have no idea, what types of patients were in these trials, because none of them, it's not just that one, even Himalaya and so on, none of them describe that. And so it becomes hard for us, if we're practicing, and let's say the patient was not a trial candidate for whatever reason, to say, well, will this patient have fit in the IMbrave 150 trial? I don't even know, because they never mentioned what type of tumors they were really treating in those. So I think that's one of the big shortcomings of the systemic therapy trials. They failed to disclose that. The local regional therapy trials, while by no means perfect, we've always talked about median tumor size, number of tumors, tumor burden, et cetera. So we kind of you get this picture in your mind of like, okay, in the Dososphere trial, this was the type of patient that they were kind of aiming towards.
Yeah, I hear you. I think that's a valid point. I do think for someone like this, though, you lose little by starting with systemic therapy and considering a consolidative tear further down. If those smaller lesions get smaller or go away, and it's really that dominant lesions that's still looking viable, most of the time we know we can at least safely combine immunotherapy and a tear, and that would be an approach that we use often.
So for this particular patient, the day before they were supposed to get a tear, a surgeon came out of the blue and said, I can resect that, and we can do intraoperative ablation for those 3 smaller tumors. And so this is what it looks like after we did that. So had a resection of that dominant 12 centimeter tumor with intraoperative ablation of the 3 smaller tumors in segments 2 and 3. About a month after the surgery, after they've recovered, we get this scan that shows no evidence of at least disease that we could see. The patient did have microvascular invasion on pathology. Do we offer adjuvant therapy?
As I mentioned, earlier, adjuvant therapy is still really under active investigation. We don't know for sure that adjuvant therapy in a patient like this with atezobev at least would provide a decrease in recurrence or survival benefit. This person is extremely high risk of recurrence, and I do worry a lot about their trajectory. But I would say as of, again, today, we don't have proof that adjuvant immunotherapy would change the outcome here.
I'm a little embarrassed, I got to say. Did I prove myself wrong here? Yeah, it's a very interesting approach.
Are you embarrassed for yourself or for the guy who did it?
No, for myself. I might have been the guy who did it. I don't know. But yeah, I think that, again, if you can end up with no evidence of disease on imaging, then that's a win. And that makes, it's a sensible approach. It's a little bit outside the box, but it does make sense to approach that way, because in the end, that's what we're all after, right? To have a scan that looks like this, where you don't see any evidence of active disease.
Can I ask, does your thought process about that change if this is somebody who you have serial imaging in and you have a sense of the, rapidity with which they sort of develop this multitude of tumors versus somebody where it's a more indolent process. I mean, often we don't have that backstory, right? Like the first scan we have is the one that we saw in the last slide.
I think if you have something that shows a more aggressive tumor biology, then your systemic therapies might be a better option than somebody who's got more indolent and slow growing disease, where the systemic therapy is not going to be as robust. Response is not going to be perhaps as robust. So that might put surgery more at the front of the option list.
And would AFP impact your thought process? No.
Yeah, I don't know. I don't pay too much attention to that. I guess when it hits like 30,000, you're like, well,
right.
But it's just
like
hard.
If it was 30,000, and assuming that you didn't see evidence of extrahepatic disease, would you have resected in that setting?
Yeah, that's a good question. Well, I'm the guy who said no resection to begin with, so it's a little awkward to say what I would have.
I mean, you say you're embarrassed, but I think 9 out of 10 hepatobiliary surgeons would have not done this. Certainly, our hepatobiliary surgeons at UCLA who have a ton of experience resecting HCC, there's no way they are going to do a surgical resection on someone with multifocal HCC. It's just not part of most treatment algorithms unless there's a certain indication or special situation.
I do think this is a circumstance too where systemic therapy really helps you understand where the patient is heading. If there's someone that you start with that degree of multifocality and they're blowing through immunotherapy, they're not going to benefit from surgery. They're not going to benefit from transplant. They have an aggressive disease biology that we probably can't turn around with any therapy, and to subject them to a really aggressive surgical procedure may not be in their best interest. On the flip side of things, if there's someone that's responding well to immunotherapy, again, thinking outside the box, remembering Heather's point, if we can ever get a person to cure, we always want to maintain that kind of mentality. And if their disease is responding well and they're getting downstage, to kind of rethink those patients that are moving leftward in the BCLC curve.
So we treated this patient before Embrave 050 came out and gave them a year of atezo-bev. And now, I don't have the follow-up imaging for this particular patient, but they're still without disease over a year later. And I believe they're off atezo-bev now, right?
Good job, Dr. Schnickel, or whoever did it.
It was Dr. Schnickel.
Oh, wow. That's, not sure how to, I don't listen to my own advice.
So variations on the theme. Let's talk about this guy, 67-year-old male. He also has HCC, but this time he has portal hypertension. As you can see by a big spleen there, 10-centimeter tumor. Sid, at your tumor board, what are you guys looking at?
With portal hypertension, it looks like he's going to need at least a right. I'm assuming not an extended right hepatectomy. And I don't think our surgeons are going to do an operation. Correct me if I'm wrong. Would you do a surgery here?
I would not.
You did not. Don't worry on this one.
And so without macrovascular invasion, this patient's going to get local regional therapy. The question becomes, are they going to be ever considered for a liver transplant, with downstaging? And that's always a huge gray zone as to, what is the official downstaging criteria. I would argue there's nothing official anymore. It's, it's kind of individualized at this point. But we would start with local regional therapy in this case, and given the size of the tumor, it would be a radioembolization.
And I don't know if I mentioned for the listeners, this is a 10-centimeter tumor that's occupying essentially the entirety of the right lobe of the liver. Dr. Burgoyne, would you offer systemic therapy over local regional therapy for this patient?
Not outside of a clinical trial. I mean, if it's a targetable lesion by Y90, and that is going to have a higher response rate than immunotherapy and a higher likelihood of downstaging this patient if that's our goal.
Are there any current clinical trials in the U.S. for BCLC? This would be actually A. So this is actually technically BCLC A. Are there any ongoing trials in BCLC A right now? It may not be offered at UCSD or UCLA. I'm just curious.
There are, and Zach can comment on this too, but the studies that are asking this question of TARE plus immunotherapy typically don't stratify by BCLC-C, more as what is the amount of tumor in the liver and is it targetable Y90? So a patient like this would potentially be eligible for one of those studies for combination. Exactly.
So we took Sid's advice and took them for a mapping procedure, and their lung shunt was 37%. Could not get an effective, or at least what I would consider an effective dose of radioembolization.
Okay.
What would you do now?
So if they can't get an effective dose, there's a couple of things that you can do. You'd have to look at your angiogram to see if there was some shunting that you could shut down. And that obviously takes a lot of study to look at your angiogram and so on. The other option is to switch, right? So in our practice, if let's say we can't figure out a way around it, we switch therapies. You go to plan B, and in this case, that's chemoembolization. We kind of forget about chemoembolization because our practice tends to be so Y90 heavy, similar to yours. But keep in mind, chemoembolization has been the mainstay of BCLC A and B for the last 25 years, close to 25 years. And so this patient would most likely get a chemoembolization without me looking at the mapping angiogram. And then we can always do the TACE, restage, and then put all options on the table again. It doesn't have to be, once you're doing TACE, you still have to do it. You can always switch back. You're not really, set into one specific treatment algorithm. You can switch to systemic, et cetera.
Yeah, so we did a round of TACE and then redid the mapping procedure, and we got their lung shunt down to about 20-25%. Still, not quite happy with the amount of dose given how large the tumor was and the size of the territory. How do you feel about systemic therapy in this setting?
Well, if all of my colleagues have said no to their technologies, this is how patients sometimes land in my clinic. But yes, if they're not a candidate for surgery due to portal hypertension, if they're not a candidate for Y90 due to lung shunting, if they've already had a TACE, we need to try something else. So I think starting a person like this on systemic therapy, either with, depending on their degree of portal hypertension and, if presence of varices or not, if those are controlled, considering atezo-bev, and if not, considering the STRIDE regimen.
The other option just to think about, and again, if you do the TACE, restage them. You can also consider external beam radiation. That's something that we really haven't discussed. It's localized to that one side. It's not diffuse. If our radiation oncology colleagues can feel like they can conform it reasonably well without getting a lot of non-target dose, that's another option you can consider.
We ended up going with STRIDE, and this guy had a phenomenal response to STRIDE. However, he did start having an area grow, now 14 millimeters, and that huge tumor is now this small little cavity. And so this is definitely new compared to prior scans. And so do we consider switching to a different immunotherapy, or what are your thoughts?
You could switch to a different treatment, medicinal systemic therapy to second line for someone that is progressing. That would be within sort of the tenets of oncology. I think putting our common sense caps on, though, looking at this, it's very small. Is this targetable now by local regional therapy? And thinking outside the box and doing a laser focused therapy on that may make more sense than treating their whole body with a new regimen that might be more toxic.
And we've seen this a lot now, especially since a lot of patients with advanced tumors, large tumors, infiltrative tumors, got immunotherapy, had an awesome response, and then, 1 year, 2 years later, they have this little nodular recurrence that looks just like this. And we've been anecdotally very successful in getting them back to a complete response, right? So, and they've been able to stay on their systemic therapy, whether it's STRIDE or atezo-bev and so on. The one thing is, in terms of adding a local regional therapy approach here, it's not just that 13.5 millimeter nodule. Every single time we do a mapping angiogram, it's going to be more than that. So to target that with, let's say, an ablation is going to be inadequate. You're going to miss. You see that small nodule, but there's probably 3 or 4 others tucked in there as well. So every time we do a mapping angiogram, we'll see 3 to 4 times as much tumor. But it's, as long as it's all localized, it's very targetable, and it tends to be very straightforward as well. And so we've done that and kept them on their the same regimen, just as you said. It doesn't make sense to completely switch, and you're burning a bridge that you may not need to burn that bridge because you want to get them 5 years, 7 years, whatever. And we've gotten durability from doing that.
So that's
completely non-science based, of course.
That's the approach we took. And you can see on the left is the SPECT-CT, taking your advice and treating the whole region, knowing that there's more disease that we can see there. And now we're back to a complete response, no evidence of disease. And you can see the expected kind of T1 hyperintensity from the radiation effect. So now we're in a situation where, did we successfully downstage? Can we think about transplant? Does the immunotherapy give either of you guys pause with transplant?
So what I'm gathering is that the total sort of presumed tumor diameter with the, issues in getting that precisely measured that you raised looks to be that it would be within a downstage criteria that we could consider transplantation for this patient. as to the immunotherapy, yes, this does become an issue. I think most programs are looking to discontinue that for 3 months or so ahead of going into transplant to avoid problems with rejection.
Yeah, I think Adam and I have a lot of experience with this. Fortunately or unfortunately, we were early dipping our toe in the water, the post immunotherapy transplant, and found that if you have an insufficient washout period, then your risk of having very dramatic hepatotoxicity, that looks like severe refractory rejection is super high. And I think that we were the center that came up with 3 months. Out of experience, that 6 weeks was inadequate for us, and 3 months seemed to work from having gone through it. So yeah, we would definitely consider transplant, but again, they have to have that washout period to ensure that, or to lower your risk. I think we still don't completely understand the process that's involved, and Adam, being much smarter than me, could probably explain the immunology behind the immunotherapy and how it really kind of changes your immune system dramatically, perhaps permanently, and again, in ways that we don't fully understand. So I think we have to be thoughtful and careful, but I do think immunotherapy can be used for downstaging.
Yeah. And I would just say, like, from a pharmacology perspective, just remember these aren't oral medicines metabolized by the liver and the kidneys that wash out in a few days after stopping treatment, as you mentioned, Gabe. These are monoclonal antibodies that last in the system for weeks and probably do have some amount of, long-lasting remodulation of the immune system that we don't fully understand, but we need to be very mindful of. And the other point that I just would throw out there as we're thinking about transplant for not versus not is for patients that are complete responders with immunotherapy or multimodality therapy, we know that the tails of these curves are quite long now. STRIDE data now out to 5 years showing overall survivors of 20%. Do patients need transplant? And I think for someone like this, the case is a bit clearer. This person, their portal hypertension actually is quite bad. They're requiring recurrent banding for their varices. Their platelets are hanging out about 50. I think, I'd be curious on Heather's input on what's their risk of death from cirrhosis alone and portal hypertension alone.
So actually, if you look at all the things that we look at to help inform prognosis, portal hypertension is the biggest predictor of mortality still. And so I would definitely encourage, if assuming that they are transplantable from, all the other angles, that be pursued for this person, if that's what they want.
It's interesting. I think Adam and I have had some cases as well, not transplant, but resection after long durations of stable immunotherapy with mixed results. I mean, sometimes you stop the immunotherapy and all of a sudden it's everywhere again, right? So I think we're still figuring this out. It's such novel therapy, and new drugs keep coming up, new monoclonal antibodies keep coming up. So I think it's an exciting time, but also one to be approached with some caution.
Great. Moving on. This is a 78-year-old male. He has a segment 2-3 presumed HCC and eventually biopsy-proven HCC, who presents found down at home. A CT scan shows rupture. How do you, Sid, manage HCC that's ruptured?
So he's obviously I'm assuming he's critically ill, right? So when against your ground rules in the beginning. And so if we were presented with this guy is, let's say he's unstable, he's going to get an embolization at this point. And in this case, we typically do a bland embolization, whether that's particles or gel foam. It's really tends to be dealer's choice. If you have a CT appearance like this with a big hematoma, active extravasation.
So that's what we did. We did a bland embolization, which tends to be our approach. I usually use smaller particles because this might be your best shot at getting any sort of oncologic benefit, at least local regionally. He has viable tumor. This is a couple months later, so you can see the hematoma is resolved, but clearly he has viable tumor. He had a big tumor that we just bland embolized. What do you think about resecting this? He doesn't have at least obvious cirrhosis. Gabe, do you think about resection in patients who have ruptured previously?
Yeah, I think it's still a legitimate option. We used to historically look at the rupture as, now they've got disseminated disease. And I don't think that's always the case. I mean, certainly that can occur. We can see peritoneal metastasis, but I don't think it's reliable. And I think that, in someone who's got, is without cirrhosis, he's got just in the left lateral section, I think it's pretty safe and straightforward surgery. So I would offer surgery.
And what do you think about immunotherapy from Rupture? Do you think it's a disseminated process, or do you think local regional, if we don't have overt peritoneal disease?
I agree with Gabe. If we don't have overt peritoneal disease, give them the benefit of the doubt. And if they're a candidate for a local approach with either surgery or intra-arterial directed therapy, I think that would be fine. I would avoid bevacizumab in a person like this that's had Rupture if I was to choose systemic therapy, but they would still technically be a candidate for checkpoint inhibitors if we felt that was in their best interest either now or down the line.
Yeah, we worked this patient up for resection. Unfortunately, the pulmonary, they had chronic pulmonary disease, so they were not a candidate. We ended up doing radioembolization, and they had a good response. I want to show a similar but slightly different situation. This patient, 64-year-old female, she was on vacation. She was also found to have abdominal pain and rupture. However, instead of having a solitary tumor, you can see she has multifocal bilobar disease. Doesn't have cirrhosis, but these are biopsy-proven HCC. Maybe there's 5 or 6 that we can see on this picture here. She was taken for emergent angiography just like before. We did the angiograms, and at least to my eye, and I'd love to get your thoughts too, Sid, there looks like there's more tumors on the angiogram here than we saw on the CT scan. It looks like almost on the left screen, almost a miliary pattern where you can see a bunch of small little tumors throughout. I don't know if you have a similar...
Yeah, I mean, I agree. This patient's got diffuse multifocal tumors. They've ruptured. Their prognosis, short-term prognosis, you can still be reasonable, but their long-term prognosis, no matter what you do, is poor, right? And so just like you did here, we would do an embolization. I think it ends up being dealer's choice in terms of how you embolize this, whether it's particles or gel foam, et cetera. The embolizations tend to be quite effective in stopping bleeding. Then the question becomes, what do you do next, right? And that's not so easy.
On the post-scan, you can see extensive necrosis, particularly of the dominant tumors on the right side of the liver. The left side tumors are still viable. They weren't targeted because they weren't ruptured. However, now we have 3 small tumors that we can see on this MRI. What do we think? More local regional therapy, systemic therapy?
Patient stable? They're patient stable, outpatient
this is
now?
2 months later.
2 months later. So I'm assuming they haven't at least yet declared peritoneal disease. So, we would still consider local regional therapy at this point, but then everything has to come on the table. Like, are they a transplant candidate eventually, right? Clearly not now, but if they're downstage, do they have peritoneal disease where they would need systemic therapy? And so on. We would probably do some kind of embolization, whether it be a TACE or a radioembolization. It's hard to say. We would have to do a mapping angiogram and determine that. I would lean away towards ablation because this patient has multifocal. It's not just the 3 tumors that are highlighted. There's definitely more than 3. So doing an ablation on the 3 that you can actually see is not really in the patient's best interest.
Mm-hmm.
I would advocate for systemic therapy for a person like this. I mean, unlike the last case, the cat's at least starting to come out of the bag here. We have multifocal disease. Obviously, she's also at risk for peritoneal seeding. And I think similar to our prior discussion, I think you lose little by starting with immunotherapy here, seeing where things head, of course, considering additional local regional therapy to some of those lesions that may or may not be responding is always on the table if it needs to be. And then again, similarly, would not offer bevacizumab with a recent rupture, but could potentially be a good candidate for STRIDE.
I would say it's probably worth mentioning that, downstaging and getting to transplant, the burden of proof that the cancer was, completely controlled to pursue transplant is pretty high in a case like this. It wouldn't qualify for the standard exceptions, but you'd have to really watch this person.
And I'm assuming you'd have to give some test of time, like 1 to 2 years.
Yeah.
Before you could.
And I don't think there's a hard answer about what that time is exactly, but it'd have to be a real long time to make sure.
I agree with that. The dogma used to be rupture equals no transplant. I think we've been a little bit more thoughtful about that, not lumped everyone into one basket, but you still have a high burden of proof to get past it. I just wonder if you go back to the last image there, I mean, you guys, I feel like we're on the Matrix where you see these screens coming, the numbers, and you guys are like reading it. Like, oh yeah, that's a miliary pattern. And I see, all I see is like, I was like, oh, is that the kidney?
Yeah.
It's the same when, our transplant surgeons send me pics of the surgical resection. I'm like, I don't know what's head and tails here. So it's the same way.
Got it. Okay.
And we have to have some magic too. We can't have you, doing all of this.
Appreciate that. Yeah.
So we decided to go with Stride for the exact reasons. She ended up having a recurrence, particularly in segment 5, where it was about 3 centimeters. We did radioembolization, as you can see the cone beam CT there, and had a complete response. And so she's doing well. This is about a year now after radioembolization. She's continued on immunotherapy. She's having no side effects or issues with immunotherapy. Do we consider immunotherapy indefinitely? Do we have a stop date? When do we consider transplant, if ever?
I'll start. We don't know the answer for these patients. The other thing I will just add is that I know you gave us the caveat that everyone has, good liver function unless told otherwise. This person has 0 risk factors for chronic liver disease and is more physically fit than anyone at this table. So what is the best answer for someone like that that's extremely healthy, now has NED? And for me, when we don't know the answers to these questions and you have a patient that's capable of shared decision-making, it's being very honest with them that, look, if you're nervous and want to continue immunotherapy for the short to medium to long term, we'll do it. If you're tired of this and want to break after a year or two to see how things declare herself, let's do that. But I'm curious too as to Heather's opinion here on would a transplant benefit her at this point?
Assuming that with everything that's been done to her liver is, still in good shape, then that's an oncologic question, right? She doesn't need it for liver function. It would be more a matter of, would that give her a better durable response to the cancer than, any other approach, including continuing her immunotherapy on an indefinite basis.
Yeah, these cases on the margin are really interesting and we just don't know the answer, right? So I think this is an area that's really, it's going to be interesting to see how this progresses, how this develops over time, because you're right. I mean, the immunotherapy can go on indefinitely as far as we know. Is that
it could.
fair?
We also could stop and she could never recur.
Right. Yeah. So how do you decide when to stop? Because that to me, I would be like so nervous that she's going to blossom and pop up. And then the other question is, if they do stop and you see disease come back, how responsive are they to restarting that same immunotherapy? Or do you have to switch?
We can re-challenge and get a response. Obviously, these are small numbers of people. It's not like we have these enormous case series, but we know even from other tumor types, and melanoma, for example, where our kind of history with immunotherapy is a bit longer, that patients that stop immunotherapy that are re-challenged can respond. I would not feel comfortable stopping any earlier than 1 year after her tear. 2 years would probably be better, but it really is a bit of a judgment call based upon how everyone's feeling at the time.
I guess my one plug for pushing for transplant in this case, I'm trying to think of patients where I've seen 10, 15, what are more tumors, and you got an NED and it didn't ever recur again. That doesn't happen. I mean, that happens like in fairy tales, right? So this patient is going to recur, whether they're on immunotherapy or not. You had that many tumors, the chance of them not recurring are way less than 10%. So my push would be for a transplant where now your post-OLT recurrence becomes sub 10%, assuming you have, not fulminant HCC at the time of transplant.
I think I agree with you in some sense. I do worry in that scenario, though. You're now subjecting a person to a treatment that, yes, we historically think of it as providing long-term durable disease control, but we're now immunosuppressing her. Is that the trigger that causes her to recur? And then I know that she's very immunotherapy responsive now. Immunotherapy becomes off the table post-transplant. And if she does recur, we run into a whole lot of trouble. So I think those are all the variables to think about. But you're right, there's no right answer. And
even you mentioned in the 5-year survival for now the immunotherapies is what?
20%.
Right. So that means 80% are dead. at
But
5
we
years,
know that
right?
people that are responders are driving that curve, that tail of the curve.
But it's still not, what's the 5-year survival after a transplant? And again, this is a difference is 80%, right? So when I think about those numbers, and again, we're not talking about 80% of these patients, right? That this might be a very different patient
that's
population.
80% of all comers.
Of all comers,
Like,
yep,
I don't know for
absolutely.
her. Yeah.
So, but we're talking 20% at 5 years for immunotherapy, 80% at 5 years for transplant. And again, it's not a fair comparison, but it is two very different ends of the spectrum in terms of overall survival. So that's why in this specific case, I think there's no right answer here, but to me, like, this patient's going to recur. There's just a matter of time.
That was great.
Hot one.
Yeah. In the sake of time, I'll probably skip this one, but I want to talk about this one. 61-year-old male. He has HCC with very, very segmental tumor in vein, as you can see here. So he has a 3-centimeter HCC in segment 2/3 with a small little invasion on contrast ultrasound into the adjacent portal vein. What are our thoughts for segmental tumor in vein? He has portal hypertension, has a tip, so probably not surgery, but you'll come into play in a second, don't worry.
Yeah. Not surgery. I'll wait for my turn. You guys go ahead.
So actually, let me ask you, would they be a transplant candidate eventually? Or what's the policy in San Diego in terms of tumor in vein? Because this is a constant point of contention and discussion in our group. Once you have PVT, are you ever a transplant candidate or not?
So again, I think this is one of those situations where the dogma is evolving, right? It used to be that was just a flat no. Now I think it's more like it depends. Where is that tumor in vein occurring, and how does it respond to treatment? Again, do you see a durable response? I still think it wouldn't qualify for the standard MELD exception. You would have to, apply for an exception if you saw a good durable response to treatment, but it isn't a right out of the gates a hard no, as I think it had been for the longest.
Yeah, I agree with that. All those sentiments that we used to say hard no. Again, that was the dogma. Now we're segmental, we're entertaining. And especially now that you have tear, you have other options on the table, we might think about it, but you have to show the test of time that you're not going to progress, because this is clearly a much more aggressive biology. So it's not an absolute anymore.
And so now it becomes the dogma or the debate of technically BCLCC, although very limited BCLCC, is local regional versus systemic, or...
So I would say there's no right answer, right? Like, no one knows the right answer here. And so a lot of it becomes experience, opinion, your institutional bias as well, whether there's a trial open, where we have trials and you guys have trials. So, if this patient fit into a clinical trial, they might get funneled that way as well.
The loudest voice at tumor board.
The loudest voice at tumor board, right? Yeah, so exactly. So let's just say trial was not available, or the patient's not, interested. Again, this is more personal opinion. This technically and anatomically seems like it would be a relatively straightforward radioembolization, where our response rates, even for segmental PVT, are the same as the response rates for non-PVT, right? They're basically identical. When are they not identical? When we start getting VP3 and VP4, when they're going down to the main portal vein, that's where we start to fall off. So I would argue that if we can do a radioembolization and we can show a complete response, then it becomes plus or minus, do you add systemic therapy? The other option is to start with systemic therapy first and then go work backwards, work the other way.
Medical oncology's opinion?
I think that's a great summary. As you mentioned, if we're following guidelines, this patient has TIV, their BCLCC, those patients have phase 3 evidence that systemic therapy can improve outcomes. So I think starting them on a systemic immunotherapy regimen is certainly reasonable. The other point I would make here, though, is I think for a patient that can have some shared decision-making, this is a good time to think about what makes the most sense for that person. That they live in a camper van in the desert and can come out for one treatment, then let's do a tear. Is their daughter an immunologist and is pushing you towards immunotherapy? Sure, give immunotherapy a try. But when we don't have a right answer, I think that either sequence makes sense to try. I don't think you lose much by starting with systemic therapy here. If their cancer blossoms throughout all areas of the liver, I don't like it's declared itself. Moving forward with local regional therapy doesn't make sense there. But if they respond well and we want to consider TARE in the future, I think that that's certainly a consideration.
For a variety of different reasons, unrelated to the anatomics, but more of patient selection, we started STRIDE, and he had a partial response within the tumor after, I think, 1 or 2 cycles. We repeated imaging, and now there's a small little dot right next to the tumor that's new. Had our best radiologist confirm it's definitely new. So we chose to then move to local regional therapy, where we did a TARE. And when we did the angiogram for the TARE, we actually saw additional 2 or 3 small little tumors, to your point earlier, kind of in that same segment 3 area, just a little bit more downstream from where the tumor was. And his tumor markers were also rising at this point. So now we've done that, and this is kind of our response. We have non-progressing. This is, kind of a typical TARE response where, maybe you see the small little black dot where that little nodule used to be, but there's a lot of parenchymal changes, again, trying to cover all the miliary metastatic disease that maybe we see or don't see from this tumor in vein. And he's continuing on immunotherapy. And so the question, which we kind of alluded to before, is this guy does have particularly bad portal hypertension and would likely benefit from a transplant medically. When do we start considering that? How long would we feel comfortable on immunotherapy without progression?
That's the magic question, right? And we tend to, pick arbitrary time frames, somewhat arbitrary, 6 months. What's the difference between 6 months and 9 months, right? Or 9 months, yeah. So, yeah, I think you get out 6 months from, from the, point where you are your baseline, and if you show stability, then you start entertaining that question whether transplant's appropriate. But I think you need at least 6 months of stability. I don't know how Adam feels about it.
I think I would quote what Heather said earlier, a good long time, which I probably would favor more like a year or 2 just to kind of see how things move forward. But you're right, there is absolutely no data or right answer to tell us what to do here. And we do have to kind of use our best judgment. But again, as I mentioned earlier, I'm always just a little bit cautious about moving to transplant too soon on a person responding to immunotherapy, because I don't want to burn bridges for the future and then lose that opportunity if they're to have a post-transplant recurrence. I mean, at the end of the day, this person did present with TIV. We know those patients are higher risk, and we have to be mindful of that.
And Adam, in a case like this, you stick with STRIDE, even though they had a recurrence on the regimen because it was a small, so you would keep going with that before transitioning. So what would prompt you to say, we got to go to,
If you need or
yeah.
Obviously, extrahepatic spread or kind of more diffuse involvement throughout the liver, clear progression that's, not subtle. I would also argue or push back a bit on, was this progression, happened very early on immunotherapy? Could this have been pseudoprogression, something that was already there that was starting to flare a bit with immunotherapy? And maybe we've just used a thoughtful multimodal approach to get the disease all under control.
What if it popped up on the other side of the liver?
You could still make the argument it's tiny. It's not like it was a 5-centimeter tumor that appeared with aggressive biology.
I think these are the questions that we're going to be asking ourselves for many years to come, especially as all these technologies get better. But I do want to finish up with one case here, which was what can happen after transplant. And so this patient was a 78-year-old male. He had HCC. And after transplant, he developed a biopsy-proven left adrenal metastasis. So what sort of options do we have systemically post-transplant?
Well, I've said it 3 times now, so hopefully it's getting across. No immunotherapy post-transplant. And there are case series showing fatalities in this circumstance, both in HCC and in other tumor types. And, unlike patients that are post-kidney transplant, for example, where we have dialysis as a backup, if someone rejects their liver on immunotherapy post-transplant, we're in a really bad place. So that does leave us towards additional mechanism of action. So as you mentioned here, this patient was challenged with lenvatinib. We don't have great data in the post-transplant space on which systemic therapy to use, so we're kind of just putting our best thinking caps on from, again, a mechanism of action perspective, and what do we use in advanced disease. I would say most people agree that lenvatinib is the most active TKI in advanced HCC, which is why that was chosen.
And he did well for 2.5 years, though eventually did develop intolerance from a side effect profile, for which we then did a cryoablation. And now you can see on a post-cryoablation, he has no evidence of disease, as far as we can tell, about a year out off of all systemic therapy. I just wanted to have a quick conversation about how we can treat these patients post-transplant.
I have one patient who had an adrenal met who did well with SBRT as well. Yeah.
I mean, I think you have to be careful, and we probably would have done the same thing. If they get an immediate recurrence, jumping into a local regional approach before systemic approach is probably unwarranted, right? Because, okay, I see this one adrenal met. Yeah, we can technically treat it, and then 3 months later, they have 5 lung mets or 3 other adrenal mets, right? So it's they need some kind of systemic approach, assuming they can tolerate it. And I would argue not just a systemic approach, but then some demonstration of stability before you consider doing, let's say, a percutaneous ablation in this case, okay? Because I don't want to just jump into it and find out on the next scan that you were just treating 1/10 of the patient's cancer cells in the body.
You haven't helped that person.
You haven't helped at all. Yeah.
What does stability mean? 6 months?
Yeah, it's
5
like
months.
A good long time.
5 to 6 months, right? No, so I mean, at the very least, 3 months, because if you just assume that we often restage patients every 3 months, right? Which again, there's no reasoning to do it every 3 months, but we do that, right? So at the very least, I want a 3-month scan showing some relative stability where this patient didn't blossom out with 5 lung and bone mets, where doing a single adrenal cryo was really not worth it for him.
247 days. That's the magic number, Zach. You're looking for it. I'm happy to provide it.
We'll have to publish it. Yeah, I'll give you credit. And with that, thank you guys for surviving Tumor Board.
Thank you.
Thanks, Zach.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for listening. See you next time.